A very good morning and a warm and hearty welcome to all our honorable guests, speakers, delegates, colleagues, ladies and gentlemen to the second day of the workshop on rational use of antibiotics. I, Ms. Ananya Mukhopadhyay, on behalf of the organizing committee of the workshop jointly organized by Ramakrishna Mission Seva Pratishthan and Medica Super Specialty Hospital under the aegis of West Bengal Clinical Establishment Regulatory Commission, would again like to extend a hearty welcome to all in joining us for the workshop. We will begin by the opening song for the day.
স্বদেশ বিদেশ উছলি উঠিছে তোমার নবীন তন্ত্র, আকাশ বাতাস ধ্বনিয়া তুলিছে তোমার মোহন মন্ত্র। নন্দিত ধরা মন্দির মাঝে ধর্মের শোক গন্ধ, মোদের বিবেকানন্দ তুমি গো বিশ্ব বিবেকানন্দ। অরুণ কিরণ উছলি উঠিল উদিল যেদিন বঙ্গে, স্বর্গ করিল সুরভি বৃষ্টি বরষি আশিস সঙ্গে। প্রেমের পূর্ণ প্রবাহে সাজিল গৌর নিত্যানন্দ, মোদের বিবেকানন্দ তুমি গো বিশ্ব বিবেকানন্দ। দুলোকের ছবি হেরিলে পুলকে গুরুর চরণ তলে, আরতের সেবা মর্তে আনিলে ভাসিয়া নয়ন জলে। বিশ্ব প্রেমের বিকশিত খনি চিত্তে হরসানন্দ, মোদের বিবেকানন্দ তুমি গো বিশ্ব বিবেকানন্দ। ভূধরে সাগরে গহনে কাননে জাপিলে কত নানিশি, তুষার হিমানি গিরি কন্দর ভ্রমিলে কত নাদিশি। অঙ্কুর পুল শঙ্কর জ্ঞান শাকের ত্যাগানন্দ, মোদের বিবেকানন্দ তুমি গো বিশ্ব বিবেকানন্দ। জ্ঞানের গরিমা গৌরব গান ভারত মর্মবাণী, পাশ্চাত্য সেথা বেদান্ত গাথা শুনি বিস্ময় মানি। স্নিগ্ধ ভাবের শক্তি মাধুরী মুগ্ধ নূতন ছন্দ, মোদের বিবেকানন্দ তুমি গো বিশ্ব বিবেকানন্দ। শিকাগো সংঘে সঙ্গীত তব শীর্ষে উঠিল ভাসি, শুনিল বিশ্ব শুনিল নিঃস্ব শুনিল প্রাসাদ বাসী। সৃজিলে শ্রীমঠ কুঞ্জ কুটির তীর্থে হরণানন্দ, মোদের বিবেকানন্দ তুমি গো বিশ্ব বিবেকানন্দ। স্বদেশ বিদেশ উছলি তোমারও নবীন তন্ত্র, আকাশ বাতাস ধুনিয়া তুলিছে তোমারও মোহন মন্ত্র। নন্দিত ধরা মন্দির মাঝে ধর্মের শোক গন্ধ, মোদের বিবেকানন্দ তুমি গো বিশ্ব বিবেকানন্দ, মোদের বিবেকানন্দ তুমি গো বিশ্ব বিবেকানন্দ, মোদের বিবেকানন্দ তুমি গো বিশ্ব বিবেকানন্দ।
Thank you so much. I would now request Justice Ashim Kumar Banerjee, Chairperson WBCERC, for the opening speech, please.
সুপ্রভাত। কলকাতা, হাওড়া, দক্ষিণ 24 পরগনা এবং উত্তর 24 পরগনা মিড লেভেল নার্সিংহোমদের যারা চিকিৎসক আপৎকালীন পরিষেবা দেন, তাদের নিয়ে আজকে আমাদের এই অনুষ্ঠান। সবাই হয়তো এখনো এসে পৌঁছতে পারেনি, রাস্তায় অসম্ভব জ্যাম, আমারও আসতে প্রায় 1 ঘন্টা লেগেছে। পশ্চিমবঙ্গে 11 কোটি মানুষের জন্য যে চিকিৎসা পরিষেবা আছে তার 2/3 সরকারি পরিষেবা হলেও 1/3 বেসরকারি পরিষেবা। বিগত দিনে কোনো রকম নির্দিষ্টভাবে কোনো নিয়মাবলী বা কোনো পর্যবেক্ষণের কোনো সংস্থা এই বেসরকারি চিকিৎসা পরিষেবার উপর ছিল না। 2017 সালে এই পশ্চিমবঙ্গ আরোগ্য নিকেতন নিয়ন্ত্রক আয়োগ জন্ম নেয়, আজ 5 বছর হলো। আমরা বেসরকারি চিকিৎসা পরিষেবার যাতে আরো ভালো করে মানুষ পায়, মানুষের যে সমস্ত সমস্যা বেসরকারি চিকিৎসা পরিষেবার ক্ষেত্রে এবং হাসপাতালের যে সমস্ত অসুবিধে পরিষেবা দিতে গিয়ে, এই সবটা দেখার দায়িত্ব ন্যস্ত হয়েছে এই আয়োগের ওপর। আর এই আয়োগের কর্ণধার হিসেবে আমার ওপর একটা গুরু দায়িত্ব অর্পণ করা হয়েছে। দেখতে দেখতে প্রায় 4 বছর, আগামী 13ই ফেব্রুয়ারি আমি 4 বছর পূর্ণ করব এই জায়গায়। তা এই কাজ করতে গিয়ে যখন আমরা বিভিন্ন অভিযোগ শুনি, শুনানির মধ্যে বেশ কিছু বিষয় উঠে আসে যেগুলো অত্যন্ত গুরুত্বপূর্ণ, এবং সেই জায়গাটা থেকে যে গাফিলতি সেই অর্থে হয়তো হাসপাতালের নেই বা ডাক্তারবাবুর নেই, কিন্তু একটু চিন্তা ভাবনার অভাব আছে। আমি একজন আইনের ছাত্র, আমরা বলি আইনে আমাদেরও নথি, পুরনো রায়, সেটা আর একটা পরের বিচারে সেটা গ্রাহ্য হয়, কিন্তু সেখানেও বলা আছে যে প্রত্যেকটা বিষয়, প্রত্যেকটা চিকিৎসা তার একটা নির্দিষ্ট অভিমুখ আছে। একটাই আমি এই রোগের চিকিৎসা করেছি এইভাবে, তার মানেই সেই চিকিৎসা পদ্ধতিটা যে আরেকজনের ক্ষেত্রে সমানভাবে প্রযোজ্য হবে তা নাও হতে পারে। সেই জন্য দরকার হচ্ছে একটা মতের আদান প্রদান। আমরা এই আয়োগের তরফ থেকে শুধুমাত্র একটা চেষ্টা করেছি যে এই যে বিষয়গুলো উঠে আসছিল সেই বিষয়গুলো নিয়ে একটু আলোচনা, আর তার থেকেই এই আজকের এই আলোচনা সভা। আমরা বিগত দিনে বিভিন্ন বিষয় নিয়ে করেছি, আজকে যেটা অ্যান্টিবায়োটিক নিয়ে, যেটা আপনারা ডাক্তারবাবুরা আলোচনা করবেন, আপনাদের নিজস্ব অভিমত, আপনাদের নিজস্ব অভিজ্ঞতা সেটা শেয়ার করবেন। আমরা কিছু বক্তা তাদের অনুরোধ করেছি এই বিষয়ে যারা কাজ করেন তারা আপনাদের সামনে বক্তব্য রাখবেন, কিন্তু বক্তব্য রাখার পর আপনাদের যে জিজ্ঞাস্য, আপনাদের যে প্রশ্ন, সেটা নিঃসংকোচে আপনারা করবেন। আজকে যদি আপনারা এই ফোরামটাকে আপনারা যদি ঠিকভাবে যদি ব্যবহার না করতে পারেন, তাহলে আগামী দিনে কিন্তু আমরা ঠিকমতো ভালোভাবে পরিষেবা দিতে পারবো না। আজকে একটা জিনিস ভাববেন যে একটা 100 শয্যার হাসপাতাল, আজকে পশ্চিমবাংলায় দ্বিতীয় বৃহত্তম হাসপাতালে আজকে আমরা এই অনুষ্ঠান করছি। 682 বেড, তো এখন 686 বেড। আমার জানা নেই, অ্যাপোলোর পর বোধহয় আর কোনো হাসপাতাল পশ্চিমবঙ্গে নেই, হয়তো আইকিউ সিটির বেডটা আমি জানি না দুর্গাপুরে। যাই হোক, অন্যতম বৃহত্তম হাসপাতাল, সেখানকার ডাক্তারবাবুদের অভিজ্ঞতা, আর একটা 25 বেডের হাসপাতাল, তার সমস্যা কিন্তু অন্যরকম। আজকে যে বিজ্ঞান যতটা এগিয়েছে এবং সেই পরিমাণ এগোনো, তার যে সুফল, সেই সুফল হয়তো অত্যন্ত ব্যয়সাধ্য হলেও হয়তো বড় বড় হাসপাতাল তারা হয়তো সেটা প্রয়োগ করতে পেরেছে, কিন্তু আপনাদের মতন ছোট হাসপাতাল, 25 শয্যা 50 শয্যার হাসপাতালে হয়তো সেই রকম ইনফ্রাস্ট্রাকচার নেই। কিন্তু সেখানে তাহলে কিভাবে রুগীকে কিভাবে পরিচর্যা করবেন, বিশেষ করে ক্রিটিক্যাল কেয়ারে, সেই আলোচনা করাটা মধ্যেই উঠে আসবে আমাদের আজকে বিষয়বস্তু, রেশনাল ইউজ অফ অ্যান্টিবায়োটিক অ্যান্ড অ্যান্টিফাঙ্গাল। কালকে বড় হাসপাতালদের ডাক্তারবাবুরা এসেছিলেন, তাদের নিয়ে আমরা আলোচনা করছিলাম। তার মধ্যে আমার একটা অনুরোধ ছিল, আমি ডাক্তারবাবুদের বলছিলাম যে দেখুন, বিজ্ঞানের উন্নতি হয়েছে, কিন্তু তার যে পদ্ধতিগুলো সেগুলো অনেক ব্যয়সাধ্য হয়েছে। অতএব এই একটা সামঞ্জস্য না করলে, যে মানুষটা আমার কাছে পরিষেবা নিতে আসছে তার কতটা ক্ষমতা, সেটাও একটা চিন্তা ভাবনা করার দরকার আছে। যেমন ধরুন, একটা ক্রিটিক্যাল কেয়ার রুগী, সে যখন অত্যন্ত ক্রিটিক্যাল স্টেজে আপনার কাছে এলো, আপনি যারা এখানে মূলত ক্রিটিক্যাল কেয়ার নিয়ে যারা কাজ করেন তারা এসছেন, আপনার কাছে যখন আসছে সেই রুগী, আপনার ইউনিটে আসছেন, তাকে যখন আপনি অ্যান্টিবায়োটিক দেবেন, দেওয়ার আগে আপনাদের একটা প্রোটোকল আছে যে আপনারা কালচার সেন্সিটিভিটি টেস্ট করে তারপরে ওষুধটা দেবেন, কিন্তু হয়তো সেই সময়টা আপনার হাতে নেই। অতএব এম্প্যারিক্যালি আপনি একটা রুগীর নানান রকম সিমটম বা হিস্ট্রি দেখে আপনি একটা ওষুধ দিলেন। আপনাকে ওষুধটা দিলেই তো আপনাদের নিয়ম আছে যে প্রোটোকল মেনে তার রেগুলার ডোজটা হয়তো 5 দিন কি 4 দিন সেটা দিতে হবে। আপনাকে আরও কয়েকদিন ওয়েট করতে হবে যে পেশেন্ট রেসপন্ড করছে কিনা। কালচারের রিপোর্টটা আসতে 5 দিন 6 দিন 7 দিন লেগে যাচ্ছে। তার ফলে হচ্ছে কি, আইসিইউ স্টেটা বেড়ে যায়, আর এক দিন আইসিইউ স্টেতে অন্তত মিনিমাম 30 থেকে 1 লাখ টাকা পর্যন্ত তো খরচা হয়, অন্তত আমার অভিজ্ঞতা, কারণ আমরা যেসব অভিযোগ শুনানি করি, বিল দেখি, তাতে মনে হয় 30 থেকে 1 লাখ টাকা পর্যন্ত, তারও বেশি অনেক সময় হয়। সেই জায়গাটা সেই পেশেন্টের হয়তো ক্ষমতা নেই সেটাকে বহন করা। সেই জায়গায় যদি আপনারা কাউন্সিলিং করেন যে বিজ্ঞানের উন্নতি হয়েছে, কালচার সেন্সিটিভিটি টেস্ট আপনারা কনজারভেটিভ সিস্টেমে যদি করেন, তার যদি খরচা ধরুন 10 টাকা হয়, তাহলে আজকে বিজ্ঞান উন্নতি হয়ে আজকে যে টেস্টটা অনেক র্যাপিড ওয়েতে, অনেক টেকনিক্যালি অ্যাডভান্স মেকানিজমের মধ্যে দিয়ে যদি সেই টেস্টটা করেন বায়োফায়ার, তাহলে তার খরচা হয়তো ওই 10 টাকার জায়গায় 100 টাকা হচ্ছে, 10 গুণ হতে পারে। রুগীর বাড়ির লোককে কাউন্সেলিং করুন যে আজকে এই রিপোর্টটা যদি আজকের মধ্যে পেয়ে যাই, তাহলে আমি পেশেন্টকে আজকের পরিস্থিতি থেকে বার করার যতটা সুযোগ পাবো, আজকে যদি পেশেন্টকে আমি যে ওষুধটা দিচ্ছি সে যদি রেসপন্ড না করে, তাহলে তার ডিটোরিয়েশন আরও বেশি হবে, এবং আগামী দিনে যখন রিপোর্টটা পাবো তখন হয়তো আমার হাতে আর কিছু সময় থাকবে না। যদি থাকেও, তাহলে বাই দ্যাট টাইম আমার 7 দিনের আইসিইউ খরচা বেড়ে যাবে। এইটা যদি কোনো পেশেন্টের বাড়ির লোককে আপনারা বোঝান, তাহলে নিশ্চয়ই তার সব দিকটা ভেবে সে নিশ্চয়ই আপনাকে কনসেন্ট দেবে। এই জায়গাগুলো চিন্তাভাবনা করবেন। আজকে আপনাদের বিষয়বস্তু একবারে চিকিৎসা সংক্রান্ত, আর আমি হচ্ছি হংসমত্যে বকজাতা, আমার এ সম্বন্ধে কোনো জ্ঞান নেই। তবু যেটুকুন আপনাদের সঙ্গে থেকে আপনাদের সঙ্গে আলোচনা করে আমার যেটুকুন মনে হয়েছে আমি বললাম। আপনাদের আজ সারাটা দিন এই podium is yours. Please help yourself and have this mechanism properly utilized for augmentation of the critical care treatment through rational antibiotic. Thank you. আপনাদের অশেষ ধন্যবাদ। এখনো সবাই এসে পৌঁছয়নি, কিন্তু সময় তো থেমে থাকে না। আর পরবর্তী বক্তা আসবেন, আপনাদের বিষয়বস্তু নিয়ে আলোচনা করবেন। ভালো থাকুন, আনন্দে থাকুন, মানুষকে সেবা দিন, মানুষকে সুস্থ করে বাড়ি পাঠান। মানুষকে যখন সুস্থ করে বাড়ি পাঠাবেন, যেন তিনি হাসি মুখে যেতে পারেন, পকেটটা খালি হয়ে যেন না যায়, পকেটে যেন কিছু অন্তত থাকে। নমস্কার, ধন্যবাদ।
Thank you, sir. I would now call upon Dr. Professor Atul Gupta, Vice Principal VIMS, for a short speech, please.
Respected Justice Ashim Banerjee, Dr. Professor, our teacher, Dr. Shukumar Mukherjee, and present delegates to this workshop, I welcome you all to this Dayananda Hall, named for the founder of this hospital, and I welcome you all to this program on antibiotic resistance or awareness about the antibiotic use. And this has become a silent pandemic, and it is present all over the world, and this has created a group within the World Health Organization, and they are observing a world antimicrobial rather, because initially when this thing was planned, it was antibiotic resistance, but later on it was found that other organisms are also getting resistant, so the thing has been changed to antimicrobial resistance. And with antibiotics, I'm a pediatrician, and we are almost married to antibiotics. We have to use a lot of antibiotics because infection is very much prevalent in children. And as in a marriage, you know, you have to handle your marriage with care. And this is how the antibiotics have to be cared for. They have to be handled with care. If it is not done, they become resistant, as in a marriage, and you will be falling into different problems. So, as we go ahead, one thing that had come to my mind while doing my clinical practice, that we should stick to protocols. Protocols is such a glue that keeps you away from the medico-legal problems. And if it is haphazard, then probably the problems are there. And with this, I hope this workshop will be very much beneficial. And as the saying in the Veda, the sahaviryang karvavahe, that is both the teacher and the student have to benefit from this this should be an interactive program, and the delegates, I will request them to interact with the speakers, and Tejasvina Vidhitamastu, that is, they will increase their knowledge, both the speaker and the delegates. Thank you all, welcoming you again to this good conference. Thank you.
Thank you, sir. We begin the first session of the day on interpretation of antibiogram and antibiotic resistance pattern by Dr. Deepnarayan Mukherjee. Dr. Mukherjee is gold medalist, MD microbiology, and is consultant physician, clinical microbiology and infectious diseases. He is attached to Woodlands Multispecialty Hospital, CMRI Hospital, and Bellevue Clinic. Sir, request you to the podium, please.
Thank you. Thank you for the kind introduction. I really feel proud to be here today as organized by our esteemed regulatory commission regarding rational use of antibiotics. Throughout the years in different forums, we discuss only on this topic. And I think in spite of several discussions, several communications, probably we have not achieved the optimum level of rationalization yet. So, I think till now we use antibiotic more on fear than on science. We think antibiotics are magic bullets and it will clear all sort of infections. And majority of the time we get something which are non-infectious. So in those cases also we use antibiotics. And that using of antibiotics, ultimately what is happening, we are going in an area or going in an era where there is antibiotic extensive resistance. So if you want to ask me what is the resistance status of our country, you can see starting from the cephalosporin, then to the carbapenems, and lastly to the drug colistin, polymyxins, all these drugs have become resistant. Maybe early in the 2000s when we started our career in the professions, then there was development of cephalosporin resistance. After we started our career, the carbapenem came and this meropenem, imipenem become resistant by carbapenemase. And later on to handle this carbapenemase came colistin, polymyxin B. And we are getting colistin, polymyxin B resistance as well. So what are the most common pathogens in our hospitals? I think this is probably the thing what we need to know, because many of the times when we start antibiotic, we don't know the hospital antibiogram, and we start broad spectrum antibiotic and a combination of antibiotic, like a good gram-positive antibiotic, a good gram-negative antibiotic. Though there is no gram-positive prevalence in the hospital, but still we use more gram-positive antibiotics. You can see in this slide that majority of the infections till today is the gram-negative antibiotics, bacteria, Pseudomonas E. coli, Klebsiella, Acinetobacter. So probably if the patient is in the hospital and develops some infection, giving gram-positive antibiotic like teicoplanin, vancomycin or others, we should think twice why you are using. Okay? And probably that can decrease the prevalence of these bacteria. Now I think we all are aware about this terminology. PDR or pan-drug resistant bacteria, XDR or extensively drug resistant bacteria, and MDR or multi-drug resistant bacteria. PDR means it is resistant to all classes of antibiotic. You cannot give any antibiotic for that patient. So why does this antibiotic resistance occur in ICU? You just see here, we use antibiotic, this causes resistance. We then use higher antibiotics, it increases the resistance, and ultimately the cycle continues. So it becomes a vicious cycle. So if one way we decrease use of antibiotic, definitely the resistance trend will also decrease. And this is the trend of bacterial resistance along with the antibiotic development. You can see from the penicillin to tigecycline, we developed antibiotic one after other, one decade after another decade. And in the same way, in the lower part, bacteria also developed some resistant mechanism to kill this antibiotic. So ultimately we are in a stage where there is no antibiotic in our list to treat our patients. Very common terminology, ESBL, extended spectrum beta-lactamase producing bacteria. These are gram-negative common bacteria, what I told you, E. coli, Klebsiella and those. And if you ask me what is the prevalence of ESBL in our hospital, it is around 60 to 80%. So more than 50% of the bacteria are ESBL producer. Maybe I will not be surprised to know if it is 90% also in many of the tertiary care hospitals. And what is the problem, you know? Many antibiotics will not work in a patient with a ESBL. After ESBL, there comes CRE. And this is the nightmare for the clinicians. Carbapenem resistant Enterobacteriaceae. So carbapenem, which was just previously thought the drug of choice for any gram-negative infection, is becoming useless. And again, you can see in Indian data, more than 50% in a tertiary care hospital are carbapenemase producing bacteria. And among them, majority will be either Klebsiella, Pseudomonas or Acinetobacter. So what is the impact of these CRE infections? Number one, it will prolong the hospitalizations. Number two, it will increase the antibiotic use. As Sir has previously told, the cost of therapy increases. So if we have to control the cost of therapy for our own patient, we have to decrease the infection rate. And we have to focus on the prevention. So we all know prevention is better than cure. So we have to focus on prevention so that the bacteria does not become much more resistant and our patient does not being infected in the hospitals. And this is one data from our one of the previous journals. You can see comparison between Indian and other country, European country, the prevalence of these infections. The carbapenem resistance, you can see we are in the highest, more than 50% compared to other Western countries. Even colistin resistance and carbapenem colistin combo resistance are also increasing in our. That means we should understand basic of this infection, basic of this microbiology, basic of this resistant detection, and also basic of this antibiogram to select actual drug in actual dose and in actual duration so that we can de-escalate the drug in a proper way. So that comes the classifications of bacteria with beta-lactam productions. You can see it is there A, B, C and D, where A is just ESBLs, B is your metallo group, OXA is D and MC is C. Why we need to know this? Because by knowing this concept, we can select our antibiotic accordingly. This is the CRE distributions or carbapenem resistant bacterial distribution in our country. You see the red part is the widespread NDM or OXA48. So these are the nightmares. And these are very notorious. The mortality rate is also very high with CRE infections. Though there are very few KPC and VIM documented from some of the hospitals. And why it is important? Again, majority of the antibiotics, you can see, will be not useful on these patients. If it is a ESBL producer, maybe your BLBLI antibiotics will go. If it is a carbapenemase producer, your carbapenems will go. And lastly, if it is a colistin resistant, you will be able to treat the patient without no antibiotic in the options. So that comes in a situation where the drug development and new drug pipeline has really come to an end. So dried up antibiotic pipelines and rising trend of infections. So in this situation, what we should do? Being a clinician, being a physician, being a doctors in our fraternity, we should have some responsibility. And what is the responsibility? I think rationalizations of antibiotic therapy. We tell you know your enemy. Who is your enemy? The bacteria. You know your weapons. What are the weapons? Our antibiotics. And you also know how to shoot. Means when to give antibiotic, in what situation to give antibiotic, when to de-escalate antibiotic, when to stop antibiotic, and when to combine antibiotic. If we know these three things, probably we will win from this battle of resistance. And antibiotic sensitivity testing and interpretation is a fulcrum for that. It is not the responsibility of the microbiology department to give you a report, but it is also an equal responsibility of a clinician to understand the report. And if there is any communication gap, there will be trouble, there will be decision problems. So, nowadays what we always advise to discuss, to communicate, that microbiology will communicate with the clinicians, and in that way combined effort, they will combinedly select a best option of the antibiotic. So why antibiotic sensitivity testing is important here? Number one, yes, we have to detect the resistant bacteria, and parallelly we have to get the susceptible bacteria and susceptibility range so that we can select the actual antibiotic. But remember, just in the ward or ICU, writing an advice of culture does not complete your responsibility. You also need to instruct the people who are sending the samples, because sample sending is most important in microbiology. If you just send me a contaminated sample of urine from urobag, I can grow 4-5 bacteria. If you can take a oral swab, I can grow 3-4 bacteria. So ultimately your purpose will not be solved, and you will be biased with culture reports. Some hospitals, some lab have given 2-3 culture sensitivity report. Now tell me what you want to treat. They have given one ET section, I got a report, 1 gram positive bacteria, 1 gram negative bacteria, and also candida. So 3 things and 3 different sensitivity. So actually, do you think patient needs all 3 things? 1 gram positive antibiotic, 1 gram negative antibiotic, and 1 fungi? Probably the sample was not good. That is the reason the many bacteria grow and fungal grow. So sample collection, sample transportation, and suggestions how to collect the sample. For urine, it should be midstream urine. For ET suction, it should be properly collected, and the sample should be sent at the earliest. That suggestions from the clinicians is very important. So when a sample is being collected, I think we should know the timeline how the reporting is being done. So lab get the sample, they do for the cultures, next day the bacteria grow. Majority of the time, on second day, the bacterial colonies grow. And that day only we put for sensitivity. Again, sensitivity will take another 1 day. Means if you send a sample today, day after tomorrow we are going to get the report. But still there are some methods by which you can cut short this sensitivity by disk, by some automated methods what we have discussed yesterday. We will not go in details of that, but for our combined understanding, this is the timeline of reporting. And what are the options? So being a clinician, you should know how are different options can be there for your patient to get sensitivity. Yes, number one or most important is manual methods, or you can say disk diffusion method. Number 2 is semi-automated system, and number 3 is automated systems. In our corporate hospitals, we do it automated systems, but in majority of the hospitals in the periphery, nursing homes, they and different laboratory also, they go for a manual methods of disk diffusions. And both of them have some positive issue and negative issue. Like disk diffusion. Disk diffusion, what are the positive issue you know? You can select any disk. Suppose in a automated machine, you have a defined disk, defined antibiotic. A, B, C, D, E, F, like 10 antibiotics may be there. But in disk, you can give n numbers of antibiotics. This is number 1. Another positive thing is that disks are cheaper. Always we should think about the cost effectiveness. For MIC based sensitivity, the cartridge is costly. Though it is giving you a better report sometimes, much more accurate report like MIC, but it is costly. And the machine is also costly. It is not possible for all the hospital and the nursing homes to put for a instrument like Vitek or microscan. And these are the advantage what I told about the automated machine is that you will get a actual MIC of the antibiotic, so that you know what should be the dose, whether there is a need of the higher dosing for that antibiotic or what are the other options. So these are different automated instruments. I think you all will be aware later on, either Vitek or Microscan or BD Phoenix. These are the different instruments which can give you a automated sensitivity methods. So the difference is again very clear that either automated or manual, you need a sensitivity. Maybe on the next day you are going to get the sensitivity. The interpretation part, again I am telling you that interpretations of antibiogram is most important. In this, what we do, we put a disc, bacteria grow and there is a zone of inhibition. We measure the zone of inhibition, and by measuring that we can say it is a sensitive or not. And ultimately we will give you a report like this, that a bacteria it's having a zone diameter maybe 20, and by seeing a chart we will say it is a sensitive or resistant. So this part is rather more important, but one thing again I should emphasize that zone diameter actually has minimum significance. Suppose ciprofloxacin has a big zone diameter of 30 millimeter and meropenem has a zone diameter of 20. Both are sensitive, but you don't be confused that higher zone diameter means much more sensitive. It is not like that ciprofloxacin is more sensitive than meropenem. So this confusion should be cleared from our mind. You check the sensitivity. You can check the break point from where the sensitivity starts, and you decide accordingly. But don't compare between two different class of antibiotic in a disc diffusion or in a MIC based sensitivity. Now coming the interpretation part, again we divide it into three groups. One group which above the cutoff, that is sensitive or susceptible. One group is totally below the cutoff, that is resistant, and one group is intermediate between these two. Suppose 20 is the upper cutoff. If it is above 21 is sensitive. 17 is the lower cutoff, it is resistant. Between 17 to 20 it will be intermediate. Okay. And in our MIC based practice, you can see there is a clear cut break point. Suppose for carbapenems, if it is 2 or 4, less than this it will be sensitive. So in both the cases we divide into sensitive, intermediate and resistant group. So like one example here, suppose this is one susceptibility report on patient. You can see whatever may be the interpretation or MIC or disc diffusion, you can see there are one antibiotic which is showing sensitivity. Just for our interest, you can see meropenem, imipenem showing resistance. That means this bacteria is carbapenemase producer. Colistin is showing I. I will discuss later on why it is written as I. 0.5 is a good MIC for colistin. And number 3, you can see ceftazidime avibactam is showing some sort of sensitivity. It is a new BLBLI which can cover one class of carbapenemase production, that is OXA48. So probably this bacteria is a carbapenemase producer, it is a OXA48 producer. That is the reason it is resistant to carbapenems but showing sensitivity to one of the BLBLI. That is the reason a proper interpretation of antibiogram is very important for a clinician to select the antibiotic. So if you give this patient carbapenem will not work. You can give polymyxins definitely, and parallelly you can give ceftazidime avibactam also in this case. So now coming the colistin issue. Colistin MIC or whatever I told it is less 0.5, but still the report is I. And it is the confusion of every clinician. I am telling you, majority of the clinician call us ki colistin MIC 0.5 and you are not giving sensitivity. Every day you are giving I. Why? I means what? I means intermediate. And he is telling why I will use an intermediate drug. So tell me whether it will be sensitive or not. The problem with the microbiologist is that we follow some guidelines, some UCAST guidelines, some CLSI guidelines or something like that, by which we follow that. So recent guidelines on colistin says, as because there is a chance of therapeutic failure, there is the nephrotoxicity issue and the drug is not penetrated in every organ, in spite of giving sensitive, we should report it as intermediate. So for colistin, don't be confused with I, you check the MIC, whether it is below 1 or not. If it is below 1, you can happily give the drug. Okay. So along with this, there is some new concept or new area, and many hospitals have upgraded them to their genotypic level, that they directly detect the bacterial resistant mechanisms. Suppose I told you sample came to me today, I will get a culture growth tomorrow. So in spite of waiting for tomorrow, I will do some test which will immediately say that this bacteria is resistant to carbapenem or not. So this is called some test like Carba R test. One of the platform like Gene Expert, where we do TB PCR, the same platform can be used for doing this test, and you can happily do that. Though you may not have a Carba R doing platform like Gene Expert, you can do by card test also. This Carba NP card, it is very easy to perform, the cost is also not very high. So you just card, you have to put the bacterial suspension, and by seeing the card like malaria card or your typhoid card, it will signal what carbapenem is produced. So in this bacteria you can see OXA48 is produced. So means it is in our previous case like an antibiogram will be like that. It will be either resistant to carbapenem or it will be intermediately resistant to carbapenems. So their presentations will be like that. And another patient is one of our patient we do on blood cultures only. Blood culture positive patients, we don't want to wait for the next day to get a sensitivity report, so that we can stop the delay in initiations of antibiotic. So we check it, and in this group of patients we will say a combinations of NDM plus OXA48. And that is, I think, probably one of the most common pattern of carbapenems in our country. Even our senior colleague Dr. V. Balaji in CMC Vellore, he also told the same. The majority are mixed with these combinations. So again, if you compare with the antibiogram by Vitek on the next day, you can see it is matching with your previous day's findings. So in the next step, I think after understanding the antibiogram, you have to keep in mind the drug regimes for the bacterias. So if you are targeting your gram-positive bacteria, like MRSA, like your enterococci, you have to keep eyes on this antibiotic list, like vancomycin, daptomycin, linezolid, tigecycline, ceftaroline. So these are the antibiotics. There are a few pipelines antibiotic like quinodalfo combinations, so which can give a better efficacy against Staph aureus, methicillin-resistant Staph aureus. Also, these antibiotics can be useful for vancomycin-resistant enterococci. So, just by seeing the demography of the presentation, you can understand for which infections what antibiotics should be selected. In the same way, if it is a gram-negative infection like E. coli, Klebsiella, Acinetobacter, Pseudomonas, so this is your organisms, and this is your first line and second line antibiotics. So start with if it is a normal patient, you can start with a BLBLI, piptazo or cefoperazone sulbactam. If there is a possibility of carbapenem production, you can start with carbapenems. And if it is a hospital acquired bad infection like nosocomial infection, where there is a possibility of this carbapenem resistance, you can definitely add either tigecycline, polymyxins, colistins like that. So I think your rationalizations of antibiotic selections will be like that, but be very bold to de-escalate the antibiotics, because majority of the time we see the patient is started with a big antibiotic. After 2-3 days there is a culture growth, that is a E. coli sensitive to all antibiotic. But the consultant or the clinician who started meropenem on that patient and getting a good response, he is very shaky to change meropenem to piptaz. And when you are being asked, he will say, it is my winning combination, patient is responding, so why there is a need? But the problem is that if you overuse any drug, any antibiotic, ultimately the hospital bacteria will be more resistant. And de-escalation has a benefit. So this de-escalation practice is very important. So for our day-to-day practices also, we can start with a big antibiotic. There is no inhibition for that. But when you get a culture report or when your patient is stabilized, be bold enough to de-escalate your antibiotics. And there are some conditions, we have to combine antibiotic. A plus B, B plus C, meropenem plus colistin, colistin plus tigecycline, ceftazidime avibactam plus aztreonam. Like that we combine. But again, that indication is also very limited. We have to understand why we are combining the two drugs. Whether my patient is severely sick, whether patient is not responding, whether the patient is having a high MIC of the carbapenems, I can give a combination then. When there is a synergy expected or not, and type of pathogens like Pseudomonas or Acinetobacter, if the MIC is in the border range, you can definitely combine two antibiotics. And for the synergy, I will say, I told this ceftazidime avibactam as per example is a good antibiotic against OXA48. But suppose it is a NDM producer, you have to add aztreonam on that, so that this combination become aztreonam avibactam. Even you can check it in the synergy testing in the lab as well. You will see the ceftazidime avibactam will be resistant. When you will add aztreonam, it will be so sensitive. So in that way, and in these few indications, you can definitely combine another antibiotic for the patients. Last, I will say, please be aware about the spectrums of your antibiotics. Many times, we don't know the spectrum of our antibiotics. My many surgery colleagues use meropenem with metronidazole in intra-abdominal infection. So when I saw them that meropenem has a very good coverage against anaerobes, no need to give metronidazole on this patient. Rather, metronidazole will be an enzyme inducer. It will make more resistance development. So in that way, with these discussions, we can decrease the use of many antibiotics. In the same way, carbapenem has a big spectrum for gram-positive bacteria also. Piptaz has a very good coverage against many gram-positive bacteria. So like that, if we understand and keep in mind our antibiotic spectrum, as I told in before, my weapons properly, then the antibiotic use can be decreased. And lastly, the PK/PD of any antibiotic, which is again very important. Yesterday, Tripathi sir has taken a very good class on PK/PD use for our patients, how we can use concentration dependent antibiotic, how we use time dependent antibiotic to come across these infections. So these are the few points for our patients to learn and the doctors to understand. So last of all, I will say the antibiotics are very precious. There is no new antibiotics in the pipeline. So we need to preserve our antibiotics. It is our combined responsibility, combined effort, which can make the world much more better for our patients. Thank you so much. Any questions from the audience?
Thank you, sir. I would now like to call upon Maharaj Shakti Pradhananda to felicitate Dr. Mukherjee with a small token of appreciation. Thank you, sir. Thank you, Maharaj. Our next session for the day is by Dr. Shayan Chakraborty. Dr. Chakraborty is a renowned infectious disease specialist in Kolkata and is currently associated with AMRI Hospital, Dhakuria. Sir will be speaking on the principles of antibiotic therapy. How do I implement my antimicrobial stewardship? Sir, request you on stage, please.
Good morning, everyone. Thank you, organizers, Medica and RKM and WBCRC for this opportunity. And why we are here? We are here because we are going through a pandemic, not the COVID-19 pandemic, but the silent pandemic of antimicrobial resistance. So the topic I will be discussing on today is the principles of antibiotic therapy and how do I implement antimicrobial stewardship in my hospital. So there is a 30% rule. 30% of all patients at any given time receive antibiotics, 30% are inappropriate, 30% of the surgical prophylaxis are inappropriate, and 30% of hospital pharmacy costs are due to antimicrobial use. So this is as per the ICMR 2018 guidelines. So this is 2023. So as per the inflation of Indian economy, so this has gone up to, I think, up to 50%. And definitely you can check that in your hospital as well. So the basic principle is all about the rights. Right patient, choose the right patient, whether the patient requires antibiotic or not. Right antibiotic, right time, right dose, right route, and right duration. That will cause least harm to the patient and least harm to the future patients. Who are the future patients? Us and our future generations. So this will cause decreased emergence of transmission of the antimicrobial resistant bacteria, better clinical outcome, less toxicity. And if you use inappropriate antibiotics, then definitely there is a chance of C. diff infection as well. So decreasing C. diff infection and reducing the healthcare costs. So this is the slide that summarizes our whole workshop of rational antibiotic use, whether infection present or not, whether antibiotic needed or not if the infection is present, which antibiotic, what dose, what duration, and once you have your cultures, review them and de-escalate. So I'll be discussing different cases to give you a better overview of the whole thing. So this is a 52-year-old male, known case of dilated cardiomyopathy, presented with cough with expectoration and worsening shortness of breath. So on examination, he had bilateral crepitations. Total count was around 11,000. This was the chest X-ray. You can see that there are bilateral infiltrations. And we started the patient on decongestive measures and started him on ceftriaxone and azithromycin, considering it can be a lower respiratory infection. So this is a very common case. We get to see this in our daily practice in any hospital or any nursing home. But what we do is that we normally continue with the antibiotics, even if we feel that this is a case of heart failure. So we did a NT-proBNP. It came as 25,000. The echo showed low ejection fraction. So we were kind of got a surety that this is not an infection, and we safely stopped the antibiotic. And patient got well with just diuretics. So this has to be done in every setup. You cannot just say that this is a case of heart failure and a lower respiratory infections. It might be together, but definitely you have to think about it. So there are many myths and fallacies of antibiotics. Firstly, we feel that the broader the spectrum we give, so it is a better for the patient. No, it's not. You have to always tailor down and target a particular pathogen. And failure to respond is failure to cover. No, it's not like that. If you try to cover everything, it will not happen. If the patient is not having an infection which will respond to antibiotic, then definitely will fail. When in doubt, change or add. So it's not like that. You have to think whether antibiotics is actually required or not. And if it is not working, if you feel your total count, CRP, these all are rising, then you can change or add. But you have to think. You cannot just simply go on adding or changing the therapy. And sickness requires immediate therapy. Definitely your patient is sick, so it requires immediate therapy, but not immediate antibiotics if the patient is not having a sepsis or maybe hypotension. Response implies diagnosis. If you, in a viral infection, if you give antibiotics, anyway the patient will respond in 2 to 3 days because the viral infection will go away. Bigger disease, newer and bigger drugs. You start experimenting with the newer molecules. It's not required. And antibiotics are non-toxic, definitely not. We all know that antibiotics are toxic and antibiotics are not paracetamols. And so how do you select the antibiotic? So it's actually quite easy. The beautiful lady at your home, you must be going out with shopping with her. You have seen her selecting her clothes. So the way she selects the clothes, you do the same with your antibiotics. So it should be pathogen directed. You need to know what pathogen that patient might be harboring and what is the latest trend. So the latest trend Dr. Mukherjee and Dr. Chatterjee, they might say that latest trend is Streptococcus pneumoniae. We are getting a lot of cases of Streptococcus. So definitely if there is a lower respiratory infection, then we should think that this case might be a pneumococcus right now in this scenario. Think of the spectrum of the antibiotic, which spectrum the patient requires. If the patient requires a broader one, give a broader one. If not, you can just tailor down the spectrum. Tissue penetration, very important. Every antibiotic does not penetrate every tissue. If you give tigecycline, it will not go into the urine, it will not stay in the blood. It will go into intra-abdominal infections and skin and soft tissue, not even diabetic foot infections. So you need to know there is a certain area that the antibiotics will go. Again, susceptibility, if an antibiotic will be susceptible, you need to know about your antibiotic flora of your hospital. Again, safety, you have to think of the other side effects and obviously the cost. If you have some good options with the lower cost, go for it. And this is a very busy chart, don't go through this. You just need to know that every antibiotic is not going to work against every organism. Certain organisms are there who are naturally resistant to certain antibiotics. Like Pseudomonas, it is resistant to tigecycline and ertapenem. And like if you see Proteus, it is resistant to colistin. So if you get a Proteus, don't give colistin, even if you have a report that is showing colistin sensitive. So usually it is not there, microbiologists will not give you a sensitive report, but if by chance, by mistake, if you see that, don't do it. Now how do you select antibiotic as per the particular syndrome? You have to think of a syndrome, where is the infection in the body? Okay, so if it is a CNS, you need to check the patient clinically if there is a neck rigidity and all. If it is a lower respiratory tract, definitely some symptoms will be there. If it's a UTI, patient will give you a symptom. You need to take the history properly and find the source of the infection. That's very important. And think of the microbial etiology, because certain different organisms will cause a certain syndrome of infection. So when you decide the syndrome, your choice becomes easier. And it's very important to know the local sensitivities, because if you are working in a big hospital, you will have more resistant infections. If the patient was admitted outside for say 48 to 72 hours, you might be having a patient who has got a nosocomial infection as well. But if you're working in a second tier city, in that place you may not have that much of resistance, so you don't require to use the higher antibiotics straight away on the go. Just think of the local sensitivities first. So this is another case, a young gentleman with no comorbidities presented with a high-grade fever and a myalgia. There was a blanchable rash, chest X-ray was normal, ultrasound was showing a GB wall edema, there was a total count was little low, platelet count was low, the patient was started on ceftriaxone and doxycycline considering to be a tropical fever. Later, dengue came to be positive and malaria antigen was negative. Now what's the plan? Since you know this is a viral infection, although the WBC count is low, the patient doesn't require any antibiotic. There are multiple papers on this. Even if the patient has got a severe neutropenia, you do not need to give any antibiotics for that. There is no evidence that prophylactic antibiotics are going to help. Yeah, if the patient has the fever for more than 7 days, you have to think of maybe the patient is going into HLH, or maybe the patient is going through a secondary bacterial infection. In that case, you might think of giving antibiotic. Otherwise, it is not required. Now, what about the nosocomial infections? So a patient was admitted in the hospital for a certain reason, and the patient developed a new onset fever. So again, try to find out the source. What can be the source of the infection? Is the patient coughing, or if the patient is telling that I've got some dysuria, then definitely you have to think of that. If you send culture reports, you might find an organism, but that can be a colonization. So if you send a repeat culture, even if you are giving the antibiotics, you might find that organism is already colonized in the ET tube or maybe in the Foley's. So think about that. You have to know your hospital antibiogram, because that will help you in selecting the antibiotic. And you start the empirical antibiotic and send the cultures before that. So that is very important. If the patient is in severe sepsis, your source is clear, target that source and start your antibiotic as per your antibiotic policy. So this is another case, 52-year-old male, a known case of COPD with acute exacerbation. He required a mechanical ventilation, and 2 to 3 days later he developed new onset fever and rising CRP and all. You send the cultures, you got a Acinetobacter baumannii, you diagnose the case to be a VAP. So this is a sensitivity, sensitive to tigecycline, minocycline and colistin intermediate. So the patient was given colistin for 7 days, there was no improvement in ventilatory parameters. So, and the culture was repeated and it came positive. So, what went wrong over here? So, the problem is that the colistin was given. Colistin is not a good antibiotic for lungs. It is a good antibiotic when you give it for UTI. And secondly, you should not use colistin singly. You have to combine with something else. But here, luckily, we have one option, not tigecycline, because tigecycline doesn't go to lungs. So, there is the option of minocycline. So, in that case, you can use minocycline. Since the patient is having a severe acinitis infection, you can combine with a high dose of sulbactam. So, here combination therapy will be much more helpful to the patient. So, you have to choose the antibiotic by looking at the culture sensitive report as well. Okay, Dr. Mukherjee has clearly described the whole topic in a wonderful manner. So, even if you have many of the antibiotics positive, you have to choose the most appropriate one, the one that will reach the source. Now, there is a concept of IV to oral switch. So, once the patient gets better, patient can take orally, you know that patient will be able to absorb the particular antibiotic. So, you can choose these oral options, fluoroquinolones, doxy, your sulfamethoxazole, trimethoprene, metronidazole, linezolid, fluconazole. So, these can be used once the patient stabilizes. Now, what about beta-lactams? We have some options, but what about this? So, what is Tiger telling? No. No ferropenem. Please do not use ferropenem. Ferropenem is not a good option from meropenem to ferropenem. It doesn't work that well. Why? Because US FDA has studied all the literatures that is available. There are 4 trials and they have shown that it is not compared against the placebo. And secondly, the studies which were showing that the study population was having a disease was not actually having a disease. So, the studies were not at all robust. We need more studies on that. And we have been using ferropenem very rampantly. I don't know why, but maybe that is the reason that we are getting so much of carbapenem resistance. So, ferropenem is something that experts are telling, please do not use it. Now, combination therapy, yeah, definitely. If it is a Tendulkar-Ganguly combination, go for it and use it in infective endocarditis, in vancomycin-resistant enterococci, in if you want to give a broad spectrum antibiotic coverage, go for it. Polymicrobial infections, in TB, HIV, definitely you have to combine. And in community-acquired pneumonia and sepsis, whenever you are giving it, empirically give a combination therapy. Once you have your diagnosis of and which organism, then you de-escalate. Now, what is the duration? Shorter the better, definitely. So, in CAP, VAP, and most cases, it is 5 to 7 days. If it is a bloodstream infection, then 10 days. If it is a pyelonephritis, go for 2 weeks. Okay, if it's a bone and joint infection, it's a separate issue. It's around 4 to 8 weeks. If it's a fungal infection, it can go up to 6 to 8 weeks. So, this is how the thing is. If you have a CAP, definitely don't give antibiotics for 10 days or 12 days. Or it's a VAP, don't go up to giving 3 weeks. It's not required. Once 7 to 8 days are gone, the antibiotics job is done. So, it is just waiting for the next infection to come. Okay. And once, if the course is done, stop the antibiotic. If the patient is in ICU, even if the patient is on ventilator, the patient doesn't require any kind of prophylactic antibiotic, because the antibiotic that you are giving, the next infection that will come to the patient will be resistant to that antibiotic. So, you are just inviting a resistant infection. Okay, just follow your infection control policies and just stop that antibiotic at the right moment. Now, if you combine the antibiotics who have got overlapping spectra, then definitely is not going to help you. So, like peptides combining with metronidazole for aspiration pneumonia for anaerobic coverage, giving dual atypical coverage like levofloxacin and azithromycin. So, these are not required. So, if you choose just one antibiotic, that is going to help you enough. So, because Dhoni and Gilchrist will not be selected in a single team, obviously, even if they are very good batsmen, but 2 wicket keepers are not required. So, this is another case, elderly gentleman, known diabetic, hypertensive, dyslipidemia. He had a history of uveitis and he was taking oral steroids for 2 months. He presented with the acute gastroenteritis in hypovolemic shock. At the ER, he was given fluid bolus, NORAD, and he was started on meropenem, teicoplanin, and doxycycline because he was severely ill. So, we did a multiplex PCR of the stool sample. So, we are fortunate enough working in a good corporate hospital. We have got this facility. So, here the patient was found to have Campylobacter, different types of E. coli, and a norovirus. So if it is not available in your setup, then it is fine, but you have to think that patient was on steroids for 2 months. So there might be some organism that is a atypical one. So you have to think of that. So what we did is that we de-escalated the antibiotic to ceftriaxone and azithromycin. So basically the patient started with meropenem, teicoplanin and doxy. So you can think of the cost of the antibiotics, and when we de-escalated, the cost really came down and patient went back home within 5 days. And ICU stay was for 2 days, I think. So this test actually helped us a lot. So if you de-escalate, then definitely you have a mortality benefit. This has been shown in various studies. So always try to de-escalate when you have your culture or at least the multiplex PCR report. Now, what is the 48-hour timeline? So at the end of 48 to 72 hours, you have to review the patient once again. You have to decide whether the patient is really having an infection that will respond to the antibiotics. Or if the patient is having the infection, is the patient on right antibiotic, dose or route of antibiotic? And can more targeted antibiotic be given to the patient? Because if you will have the cultures by then, and then you can think of the de-escalation. And how long should the patient receive the antibiotic? At that time you can decide, yes, the patient is having a respiratory infection, I will give it for 7 days, commit to that, right, for 7 days. Then your sister will, by default will stop the antibiotics at 7 days. If you think that no, it's a like a joint infection, then you have to give it for more time. Okay, so that time you have to commit. So this is a very interesting case. A young gentleman known dyslipidemia presented with fever, headache, loose stools, history of syncope, rash over the chest, and episode of vomiting, epigastric pain, discomfort. He was found to have tachycardia, tachypnea, hypotension, and bilateral conjunctivitis. So there is a constellation of symptoms, so many of them. He was started on IV fluids, ceftriaxone, and doxycycline. In the lab reports, he was found to have CRP was very high. He had an elevated tropi. He had an anti-proBNP of 7,000. And all the cultures were negative. Scrub typhus, dengue, and all were negative. His stool multiplex PCR showed all types of E. coli. So, and an elevated D-dimer ferritin fibrinogen. And his INR was 1.5. So, you have got so many symptoms. You have got so many positive lab reports. So, what do you think? What should be done? The patient was not responding to ceftriaxone doxycycline. So what do? Escalate to meropenem and continue doxycycline. You plan for a coronary angiography and angioplasty. You stop all antibiotics and give steroid and IVIG, and you stop ceftriaxone doxy and start acyclovir. So mostly if you don't think in the line what the patient is giving you, you will definitely escalate the antibiotics. It will not respond. You will again escalate to ceftazidime, ivactam, colistin and all, patient will not respond. So what we did, we stopped all antibiotics and gave steroid. So this was actually a case of multisystem inflammatory syndrome in adults that we have seen in post-COVID area. So this is one diagnosis you have to think of it. So many symptoms, so many lab signs. You put it in the case definition and all the clinical and lab parameters, you will definitely get the diagnosis. We stopped all antibiotics and gave steroids and it worked like magic. So why antibiotics fail? Because in the last case you have seen, you have to firstly think. You cannot just blow a tire like with your mouth, you have to use something else. So if there is a colonization, definitely your antibiotic may not work. There is a problem with the antibiotic regarding the spectrum or the penetration, it won't work. Penetration problems, if there is a big abscess or a foreign body, it won't work. You have to remove the foreign body out. That can be a particular device. So it can be Foley's or central venous line or any other device. If it is infected, you have to take it out. There can be non-infectious diseases like mimickers, autoimmune diseases, any kind of drug fever, then definitely you have to think of it. And certain unresponsive ID conditions like viral illness or fungal infections. So this is another case, elderly gentleman, he had a history of pacemaker insertion and came with history of fever with tachycardia. He was found to have an infective endocarditis that grew Candida guillermondi. So this is the culture sensitive pattern. So echinocandins are sensitive. So what is the next plan? Your choice of antifungal, dose and duration of antifungal and what? So what we did, we chose micafungin. Micafungin normal dose is 100 milligram, but in this case, in infective endocarditis, you have to use 150 milligram once daily. If you use 100 milligram, patient will not respond. Again, you have to think of the device, what to do. It is already infected, remove the device and go for a valve replacement, because you can just open your books, you can see that what are the indications of surgery in infective endocarditis. You will see that there is a, if it is a fungal endocarditis or there is a perivalvular abscess, there's a huge list out there. So you can just have a look and you will find that the patient needed a valve replacement. And you have to continue the thing for 6 weeks post-surgery. That is very important. If you stop the antibiotics within 3 to 4 weeks, again the patient might come back with you with the endocarditis. And please, endocarditis do not have any therapeutic concentration in urine. If you get a candiduria which might be resistant to fluconazole, don't give echinocandin, it doesn't penetrate urine. Micafungin does a little bit, but if you have an option of flucytosine, then definitely use flucytosine in that case. Or if required, ampho, not this echinocandins. Now, how about the implementation of this antimicrobial stewardship program? So I will just share my experience, what I did. You can just maybe extrapolate that in your hospital. The first and foremost is the antibiotic policy. You need to have an antibiotic policy. So you can utilize the ICMR document, or we made a document in AIIMS New Delhi also. So you can use that document and maybe make this one in your hospital. So what you require is a very important infection control policy, because that is an absolute necessary, because you need to stop the infections inside hospital as well. You need to have your antibiogram. You need to know what all organisms are growing in different samples, urine, blood, respiratory, skin and soft tissue, like we have E. coli, Klebsiella and all. And you need to know the susceptibility pattern of each organism. That is very important, because once you know that there is a UTI, you can think that this might be E. coli, and that E. coli might be carbapenem sensitive, because we have a sensitivity of around 70%. So you can target with a carbapenem once it is a hospital acquired infection. So you can prepare an antibiogram. Now regarding the AMS team, so the ideal AMS team as per the ICMR guidelines, you need to have a ID physician, you need to have a clinical microbiologist, ID pharmacist, and your support system will be your information system and the infection control committee. So in my team, I am the AMS leader. We have a wonderful microbiologist who guides us. Primary treating physician should be part of the team. That is very important. You need to take that person in confidence that your patient requires certain antibiotics and doesn't require some others. So you can stop the antibiotics as and when required, so that importance is there. The registrar, clinical pharmacist, ICN, advisory panels, we have critical care consultants and our MS, and we have the supportive panel as well. Now you need to identify the patients. The high-end or the restricted antibiotics that is there in the antibiotic policy, any patient on that will be required for AMS. More than 3 antimicrobials together will be considered. Any antimicrobial for a duration more than 5 days will be considered. And from the OT, you can get the list of patients who are getting prophylactic antibiotics. These are the list of high-end antibiotics that we go for the rounds and check for these in the patients. This is the proforma that we made in our hospital, and we go and fill up this proforma, discuss with the treating team that your antibiotics need to be changed, or you continue with the same for this duration, or there is a renal problem, the creatinine is high, you have to change the dose of the antibiotic. So these all things we discuss and we come to a common conclusion. Now we are doing a AMS. How about the outcome indicators? How do you know that AMS is working? So you can check the consumption of the antibiotics. That is easy because your pharmacy will give you the data. You can keep a record of the days of therapy. You can keep a record of mortality, hospital length of stay, ICU length of stay. Okay. So this is just a small data I can show. All these red ones were the antibiotic use that was quite high. And you can see ceftazidime avibactam, it was around 267 DOT, it came down to 131. So once you go on with your AMS, you take the team under confidence that things are going to work, don't worry, we are there to support you. Then slowly things will happen and antibiotic use will go down. This is what we have done, and you can see it is reflecting that we were kind of successful, but again, there will be ups and downs always, so that is okay. And this is the antibiotic sale data from the pharmacy. Again, the antibiotic sale, at least I can say that something has come down, and there might be again a little bit When the more severe patients come, when there is more resistant cases we see, then definitely there is a rise, and again it calms down. So you can use these links for learning about AMS, and you can always do a self-audit of your program. And thank you so much. Please handle antimicrobials with very much care. And if you have any questions, I will be happy to answer. Yeah, Dr. Roy.
Excellent presentation, sir. So excellent presentation. I just have one question. A lot of our institutions do not have multiplex PCR. What is the utility of using CRP, and if the institution does have it, procalcitonin as a guide for tracking response to antibiotics in patients where clinical signs and features may or may not be changing very effectively, as a guide to either both starting antibiotics as well as maybe stopping antibiotics, or upgrading, changing antibiotics? Thank you.
That is a very nice question, because yeah, definitely many institutes will not have PCR, but Procal is very one good test to monitor the patient for the response. It's not something that you will diagnose with the sepsis with Procal, but once you have a baseline Procal, and then you can just maybe check after 5 to 7 days that it is coming down or not. If it is coming down, if it is less than 25%, then you can think of stopping the antibiotics. It's like with the CRP. But Procal is an expensive test, so instead of Procal, you can use the CRP as well. So you can check the CRP, and it is supposed to come down eventually when you are giving the appropriate antibiotic to that particular patient.
Just to follow up on that, is there any link between the level of the CRP and the likelihood that it's a viral infection versus fungal versus bacterial?
Studies have not come up with this, that this 350 will be a bacterial or maybe 150 will be fungal. It's something not like that. But if it is a viral, it doesn't go beyond say 100. But we have seen in COVID cases as well, you have seen 150, 200. So there is no particular cutoff like that.
Dr. Chakravarti,
Sir.
I have got two questions. Number one, how frequently you do the auditing? Because auditing is a very dynamic process. Second question, how much time do you take to give the culture report to the clinicians to adjudicate proper antibiotic therapy, either initiation or de-escalation?
So we do the audit twice or thrice a week, because my clinical pharmacists are there, they're very active. They go to their rounds daily, and I usually go there twice or thrice a week, because it's difficult for me to go every day. And regarding the culture report, suppose today we are sending a culture, next day I will call the lab that what culture it is growing. So they tell me that if it is a gram-positive cocci that is growing, or a gram-negative bacilli that is growing, that is a lactose fermenter or non-lactose fermenter. So in that case, if it is a GNB growing, I can safely stop the ticoplanin if someone is given. And next day, we get the final culture report from the lab. So on the second day only, we get to know whether it is a GNB or GPC.
How many cases turn out to be positive?
So, like you are asking the culture positivity.
In the blood culture?
Blood culture positivity, sir, is around 40 to 50%, is not much.
Thank you.
Thank you, sir.
Dr. Chakravarti, I have a question, being a non-medical person. With your experience for an ICU stay for 15 days, how many procals should be there? Because it's a costly test. And Dr. Chakravarti, I'm facing this problem because the bills are for scrutiny coming before me. How many procals you will maximum you would suggest?
So firstly, I'm myself quite afraid of Procal because it is a very costly one. So I prefer CRP. Okay. And if someone wants to do a Procal, so what I feel is that because firstly, you have to decide how many days of antibiotic you want to give. So if it is a case of respiratory infection, I give it for 7 days and then I stop. So you need to do a firstly a baseline Procal once the antibiotic is starting, say on day 0 or day 1. And once you're planning to stop the antibiotic, say at 5 or 6th day, you can do a Procal.
So twice is all
yeah,
right.
If it is a 7-day therapy, then twice. If it is a 14-day therapy, then maybe thrice. But I personally prefer CRP.
And thank you for giving me this idea. that the result you can achieve in CRP without doing a Procal.
Yeah, but
And
CRP.
that is much cheaper.
Yes.
That is much cheaper. We have already capped the investigation cost, where Procal we are allowing 4,000, CRP is 1,000. So it is 1/4. So what could be done through CRP? But in each and every case, Procal is not necessary, is it?
If someone is checking a baseline Procal, it is mainly important because if you feel that is it a bacterial infection or it is a non-bacterial infection or is it an infection at all. So in that case, Procal may be required. So that is the baseline one that we are doing. After that, we are mostly following with CRP. But sometimes what I have seen that I do a serial CRP, like in 2 to 3 days, once I am doing, and sometimes the patient responded, but suddenly there is a rise of CRP. So here we can see that in the time we are giving the antibiotic, the patient might become non-responsive to that antibiotic. In that case, we have to escalate it. Recently, this thing happened.
That is after 6-7 days.
After 3-4 days or 5 days.
3-4 days.
Yeah.
Because my concern is the cost.
Absolutely, sir.
That's why.
Absolutely, sir. No, sir, Procal can.
Many times we can find that CRP is high, but there is no infection. But procalcitonin more or less give the sign that the patient may have infection there.
Dr. Mukherjee, why I have asked this question, you have understood.
Yeah. It's
On the cost aspect. Yes.
So I would just add to what he said, because there are a lot of studies that have gone across the world. Sir must be laughing at me, because procalcitonin has often been junked by Western world, because there are reports which say it's neither sensitive nor specific. There are a lot of causes of stress which can give you a high Procal. So a Procal is positive, meaning it's an infection. It's probably not the game. The game lies only there where there are reports which have shown that if you want to de-escalate antibiotics in ICU, maybe there the Procal may have a trend, may help you. So Procal can only help you in de-escalating antibiotics in ICU in certain cases. Right, Dr. Roy? It does not help you to start antibiotic. No one can confidently tell that Procal is positive means your patient has infection. Creatinine is high, Procal will be high. Your patient has burns, Procal will be high. Your patient has other stress, Procal will be high. Procal will be low initially, it can rise later. So negative Procal, you cannot say there is no infection. Positive Procal, you cannot stamp that there is an infection. So clinical parameters along with other, exactly. Context is very important. Black and white is not possible.
One tricky question.
Sir.
By your effort as an infectious disease specialist, how many physicians in your institute are following the antibiotic stewardship program?
So that is the most tricky question, obviously. But I've shown one photograph where there is a handshake.
Now that is an important question.
Yes, absolutely.
How much you can convert a negative to positive by your effort with all this antibiogram?
Yes, sir. So this is what we call as handshake stewardship, because here you need to make friends with the treating team. You need to bring them into confidence that your antibiotics will work, or you have to stop the antibiotics on the right time. So it will take some time. It will not happen in 1 month or 2 months. It might take 2 to 3 years. I have taken around, say, 6 months to 1 year for this. Yeah, but the person on the other side, the treating physician, has to be think that yes, he's telling right, he's not wrong. So I have to prove myself also to that person.
You have to carry forward every year.
Exactly, I have to carry forward with every year.
Then you can.
Absolutely,
then
sir.
Your effort will be successful.
Absolutely, sir. So I have shown the DOTs and all, so that has come down. With persistent efforts, that has come down. So everywhere ID specialist will not be there. So the treating physician has to do this by himself or herself.
Then you can curtail the 30% cost, rule of 30%.
Absolutely. So it is now 50%. It has gone up.
There is one more embarrassing question. Many a times we find there is an allegation that, you see, you are prescribing whatever medicine you are prescribing, it is in a generic name. Is it? Now, we have already given our advisory to the extent that your pharmacy must have at least 4 brands. And that particular brand is chosen by the pharmacist or the shop, that boy who is just complying with the requisition. Now, many a times we find that, take the example of meropenem, which is available from 550 to 3,500. And mind that each and every medicine, they are on in the market after getting a valid license. So can you say, as a doctor, can you say that this particular medicine I want, this particular brand? Can you say that, sir?
Sir, as per my practice, what I do is that I write the generic name of the medicine.
Yes.
Okay. And there are...
That you are supposed to.
That I am writing. That
Yes.
I do. But every company that has got a license.
Yes.
So that doesn't mean that every molecule will be as effective as the other molecule. We have seen our practice. Every physician sitting over here who writes antibiotics must have faced the same problem. I write meropenem. There is a certain, say, I am Shayan Chakraborty, there is a Chakraborty Pharmaceuticals who have prescribed, they have got a meropenem for 400 rupees. I write meropenem and they are giving that merochoc. Okay, so I don't know it will work or not, but if I give a meropenem of a reputed brand, like we always buy clothes or shoes from a reputed brand, we don't go to...
Reputed, quote unquote, is a relative term.
Reputed means the one that works. I'm not saying that
Yes,
some
yes.
big brand or something, one that works, one that my teacher has used and he has given me that this particular brand is good, you can use that because it works, it has happened with me. So that is the reputed thing. But if we start writing like generic for every patient, it may or may not work because either it will not work or it may have delay in working.
Sir, I tell you, I am giving you an example because this question I am facing every day while hearing the complaint. A patient is having ICU stay for 10 days. Meropenem is a drug which I find in many cases, a substantial number. You are suggesting 1 gram thrice a day. So for this 7 days stay, he would have 21 meropenem. And this 21 meropenem, if it costs 3,500, which could be done at 1,000, then 2,500 into 21, the patient has to pay through his nose. So there I feel, and I appeal to all of you, that you have some moral responsibility. As you were saying, honestly saying, you have the courage to say that particular brand, at least that would inspire confidence in me. Then you vouch for that. Every time we say that when this question comes, we ask the hospital that you ask your doctor that this particular medicine, he would vouch for that, we would not say anything. Yes, please, please.
Probably on this topic also, the place for opinion-based decision has gone. You will find there are certain papers which have tested relative potency of antibiotics. A couple of such papers are there from my institute. Dr. Bhattacharya spoke yesterday. 2 papers he has published. So it is shown and it is known that high-end antibiotics, meropenem, colistin, fosfomycin, potency is not the same. Your relative potency means how potent is your antibiotic to kill the bug with the same concentration. It has been shown that not only there are certain brands whose potency is really low. So if what we have, all NABH accredited hospitals have to write their generics along with the brand name if you want to. And that is also mandated by NMC or MCI or whatever. I feel that there should be a certain kind of liberty for the hospitals because in India we don't have quality assurance. I would not name a company. There was a big deal of problem in my hospital. there was impurities found in the chemotherapeutic agent. So we don't prescribe that antibiotic. And a recent molecule they have launched, we have said we will not keep their antibiotics. We have decided, we have a hospital drugs and therapeutic committee. So that is not possible in all hospitals. Since we work as an institute, probably we have that facility. But what I would say is, it's a right approach to keep 2, 3
Sir,
or 4
your
brands.
hospital?
Tata Medical Center. Yeah.
You
Yeah,
can't,
so
that's,
I would just
why,
come to that.
Why I ask you, you can't
that is what I'm telling.
take the
but,
others
but
at
I
par.
would
Yes,
say,
please,
sir,
please.
that your approach is right. We keep 3 brands of each
Yes,
molecule.
yes.
And the policy matters, and that brand decision is taken in a committee. That is the problem. So,
Sir, there is one more thing, as you were saying. You have said reputed brand. Do you consider Cipla as reputed?
Yeah, Cipla is
Yes.
reported.
Cipla is selling human albumin at 4,000, and we are often confronted with a bill which is having at least 5 human albumin, 5 units at the rate of 6,500. Now this 2,500 into 6, how much it comes to, sir? 15,000 the patient had to pay through his nose. These problems we are appealing to you. You, the people, as sir has said, that every medicine, every brand does not have the same efficacy. If that is so, then you come and you vouch for that. I have no problem. I have no problem. But that is not being done. What we have done, sir has done, that in case of meropenem, we have made a benchmark of 1,000. So what we are doing, whenever any bill comes to us for scrutiny, we take it as 1,000 and delete the balance part. But this is not the right approach, but this is a time gap. You, the doctors, you should at least come up and take the responsibility to identify the right medicine at the right cost.
Thank you so much, sir. Thank you.
Thank you, sirs, for the wonderful discussion. I would now like to call upon Dr. Aviral Roy to felicitate Dr. Chakraborty with a small token of appreciation. We will now take a break for 10 minutes and be back after the tea.